Good morning, everybody. Am I audible? I'm Dr. Sujit from the orthopedic department. So can somebody just type whether I'm audible or not, then I'll go ahead with the class. Jyoti raised hand. है ना? Okay, dear students, I'm going to start the class on polytrauma and open fracture. So I have quite a lot of slides, I think around 1993. So I will not be able to finish within 40 minutes and I'll have to extend the session. So please be patient with me. And now we shall start the class, okay? So this is an important topic, polytrauma and open fractures. It's supposed to shift. Okay, first, the polytrauma. So if you just look at this picture, in this picture you see his forearm is injured and his pelvis is injured. So you can get some idea that at least two body systems are involved. Okay, in this region in the pelvis, so below is the bladder and a little bit up is the intestines. So maybe he has some abdominal injury also and some pelvic visceral organ injury. So the polytrauma means at least two systems of the body are injured and out of which one is life-threatening. Okay, so this is a simple definition. Okay, so I just read it to you. Polytrauma is a term describing injured patients who have sustained injuries to more than one body region or organ system, of which at least one is life-threatening. Okay, this is the definition. In exam, you're supposed to write this definition. But we have a more detailed definition. This is the New Berlin definition, which was given in 2014 and by the international consensus. And it is a nice to know thing, okay? This in exam, if you're right, that's good, but at least just know there's something known as New Berlin definition in polytrauma, okay? So it just redefines the presence of two injuries that are greater than or equal to 2 or equal to 3 on the aggregate injuries scale and one or more of the following additional conditions. Okay, this means, so there is something known as the aggregate injury scale, and in this two regions are involved, okay, and at least it has a grade of score of 3. Okay, so this I'll show you a little bit later. So aggregate injury scale means the body is divided into 6 parts and the region injured gets the number, and the number is from 1 to 6. Okay, so region 1 is head and neck, 2 is this face, 3 is chest, then we have the abdomen, then the extremities and the pelvis and external. Okay, and there's a, according to the severity, there's a grading from 1 to 6. Okay, so at least 2 injuries greater than or equal to 3 on this. Okay, there are 2 regions and it should be at least 3. Okay, with plus this condition at least should have 1 or more of the following, like hypertension, systolic blood pressure less than 90, unconsciousness, Glasgow Coma scale less than 8, acidosis, that is base deficit less than or equal to 6, and coagulopathy. Okay, INR, international normalized ratio greater than or equal to 1.4, and age is 70 years. Okay, so this is the New Berlin definition. Okay, so this is a nice to know thing, but at least the first definition you should be able to write in the exam. Okay, And polytrauma and multiple fractures are quite different things. Okay, multiple fractures means several bones are injured at the same injury. There is only involvement of the musculoskeletal system, not of the organ system. Okay, so there are a lot of trauma scoring system like Glasgow Coma Scale for the head injury, injury to severity score, okay, and the mangle extremity severity score. Okay, so this injury severity score, I'll just show it to you. So this is the injury to severity score. Now this injury to severity score is based on the abbreviated injury score, which is included in the definition of the Berlin definition. So there are the 6 regions, okay, and each gets a number. AIS means abbreviated injury score, okay. So the Berlin definition is just limited to the abbreviated injury score, okay. But if you say of the injury severity score, then what you have to do is you have to just square this, okay. And the 3 regions which has the highest number, you take this. Like in this case, we have 3, 4, and your 5. Just square it, and total gives you 50. So injury severity score, it ranges from 1 to 75, okay. So this is quite detailed, and this is also just nice to know thing, okay. So if you just take not the abbreviated injury score, which is included in the polytrauma definition, just the injury severity score, if you take that, and if it is more than, if you, now in this case is 50, but if you just add up and it is just 15 or greater, then that's also considered a polytrauma, okay. So then we have a MES score, mangle extremity severity scoring. This is to decide whether the limb, the crushed limb, has to be amputated or not, okay. So if the score is more than 7, then you cannot save the limb, okay. You cannot salvage the limb. Salvage means to save. You have to amputate it to save the life, okay. So again, there are categories, okay, like and the scores are given like skeletal and soft tissue injury. Here this, it just depends on the injury and the limb ischemia, presence of shock, and age of patient, and they're all the scores, okay. And when you add up, it is 7 or more, then you are justified to amputate the limb to save the life, okay. So trauma deaths. So immediate trauma death happens due to severe brain injury, okay, and disruption of aorta, a large vessel. And early means minutes to few hours. It could be due to intracranial bleeding, hemothorax, hemopneumothorax, splenic rupture, and liver rupture, okay. And late, it is 2 weeks after injury. It could be due to sepsis, fat embolism syndrome, or multiple organ failure. So if you see this, always in polytrauma, is just not the orthopedic surgeons that are involved, okay. But in our part of the world, when a trauma patient comes to the emergency, always the orthopedic surgeon is called. That is wrong, okay. The trauma team consists of general surgeon, orthopedic surgeon, neurosurgeon, vascular surgeon, okay. So it's a teamwork, okay. But here, a patient comes, okay, with a compound fracture, and he has a liver injury. First, everybody sees the compound fracture, okay, not the liver injury. So these are missed. So, and there have been protocols developed so that we do not miss this, okay. So, and mortality increase with increasing age of the patient. So now the golden hour. Golden hour, it states that like after 1 hour, with every half an hour increase, there is 3-fold rise in the mortality of the patient. So it means that you have to intervene early, okay. So now to intervene early and to develop a systematic protocol so that we do not panic in the emergency when the polytrauma patient come. So this has been developed, advanced trauma life support, okay. Now this is a gold standard for the initial assessment and treatment. It is not only for the assessment, it's also for the treatment, which goes on simultaneously, okay. So it's the gold standard for assessment and treatment, okay. So now this is a training program, and it was developed by James Steiner in 1976, okay. And it says that like during stress, the treatment protocol may not be followed, okay. You may make the mistakes. So attention is given to the compound fracture and miss the obstructing area, okay. And it is very rare for major musculoskeletal injuries to be life-threatening in the absence of catastrophic hemorrhage, okay. Only if there's hemorrhage, then the patient will die of the musculoskeletal injuries. Otherwise, he'll die of something else, which I just told you, like the brain, head injury, rupture of aorta, cardiac tamponade, okay, which can be missed, okay. And one interesting thing about this James Trainer is he himself was an orthopedic surgeon, and he crashed in his private plane. This happened in the United States, and he was so ill-treated in the hospital, ill-managed, and it stimulated him to develop this ATLS protocol, okay? So this is the story of James Steiner, how this ATLS protocol came about, okay? And this ATLS protocol is different from others. Don't confuse with this basic life support and advanced life support, okay? So this consists of primary survey and simultaneous resuscitation, and secondary survey, and then the definitive care. So in primary survey, rapid assessment and treatment, okay, just start the treatment. The secondary survey, once the patient is settled down, then head to toe evaluation, okay? Then later on, the definitive care. So initial assessment is the ABCs, okay? ABC, D, and E, okay? So airway, breathing, circulation, disability, and exposure. So first, the airway, okay? Assume there is cervical injury unless ruled out, okay? Unless ruled out, we have to assume that there is cervical injury, so don't move the head here and there, okay? So it has to be immobilized, okay? In cervical collar, a head supports. If you do not have cervical collar, just put 2 sandbags, okay? On either side of the head. And look, listen, and feel, and you do a chin lift and the jaw thrust. So when you do this, what happens is the airway is straightened, okay? So either you do chin lift, head tilt, or jaw thrust. The aim is to just straighten the obstructed airway, okay? Then check for breathing, then the circulation, okay? Signs of shock, okay? Prolonged capillary refill, tachycardia, and hypotension. Looks for external bleeding, okay? This is obvious, okay? Bleeding, like maybe there's a mangled extremity, open fracture, limb amputation, but some will not be obvious, like the cardiac tamponade, okay? Now suppose the blood pressure is dropping, okay? The patient is going to shock, but you do not see any external hemorrhage. Then you have to look for all this: cardiac tamponade, hemopneumothorax, or bleeding in the pelvic cavities, okay? So, and you are at the same time assessing and the same time you're treating. So now if you have found pneumothorax, you have to decompress. Don't continue your just examination. You found the problem, then just treat it there. Like you have to decompress the body cavity. If there's tension pneumothorax, you have to decompress it, okay? Just put in the needle in the chest. Cardiac tamponade also you have to drain, okay? Epidural hematoma also the same thing. Simultaneous treatment, assessment and treatment. And disability, now you in disability is you assess the neurological status and you do a GCS, Glasgow Coma Scale scoring system, okay? And when there's a low GCS, until proven otherwise, it is due to cerebral injury, okay? And if it is less, you have to intubate the patient, then continue with your assessment. You just intubate, then continue with the assessment, okay? Don't do all the assessment, then intubate. So that is the logic of this ATLS. So this is the Glasgow Coma Scale, where there are 3 groups: eye opening, verbal response, and best motor response. I'll not go into the detail, but just remember that best response is 15. And if it is 8 or less, you have to intubate, and unresponsive 3. Okay, there's no 0 in this because no response all has 1-1 in the scoring. Okay. So the exposure. So all the clothes are to remove for a full examination. Okay, and maintain the body temperature. Don't let there be hypothermia. Okay, because what happens in hypothermia is there'll be peripheral shutdown, and the cellular oxygen demands will go down. Okay, so a peripheral shutdown, don't let it happen. So maintain the patient. You can keep the blankets, okay, and warm the patient. And also when you're giving fluids, it's good idea to warm fluids, okay, not just infuse the cold normal saline. Now once the patient has settled, then you come to the secondary survey, okay, and the components are history, examination, and if required, tubes and fingers in every orifice, detailed neurological examination, further test and re-evaluation. Okay, this is secondary. So history you can take about the mechanism of injury, okay, then any medical conditions or any personal history like alcohol, smoker, and because you have to plan. So suppose somebody is taking alcohol, he takes daily, then after admission, maybe after 4 to 5, he doesn't take alcohol, he have alcohol withdrawal syndrome. So all that has to plan. So you take a detailed history, okay? An examination in the head, you just look for contusions, hematoma, which would be extradural, subdural, and base of skull fracture. If there is, then there'll be bleeding from the ear, and there'll be CSF rhinorrhea from the nose, okay? And look for any facial bone injuries, neck for contusion, damage of tracheal larynx, airway obstruction. Come to the chest, okay? Contusion, rib, sternum fracture, heart-lung contusion, pneumothorax. If there's pneumothorax when you examine, okay, there's hyperresonance when you do a percussion. And if there's stony dullness, it's a hemothorax, okay? Maybe in the primary survey, you missed it. Now you are doing a detailed examination, you have found it. Now then put a chest tube, okay? So assessment treatment goes side by side, okay? An abdomen, if it's rigid, tender, absent bone sounds, could be due to visceral injuries. And when we do not do most of the time, but you have to examine the perineum and the rectum, okay? You have to do it for the abdominal examination. And pelvis, you do a compression test. If there is any sacroiliac joint disruption, pelvic fracture, and if there's previous bleeding, there is definitely a urethral injury. And this compression test, if somebody has done and is positive, no other surgeon or doctor should go and do it again, okay? Because what happens is, there's bleeding. When there's a pelvic injury, the patient can die of 2 ways. One is from the injury to the blood vessel. The other is the bleeding from the pelvic bone itself, which is a cancellous bone, okay? So either bleeding from these 2 areas, clot has formed and the patient is settling down, the BP is coming down, but somebody goes and again does the compression test and dislodges the clot, then again the patient is going to shock. So if it's documented, now the other person should not go and again do the compression test, okay? Then the limbs, okay? If there's deformity, you just apply splints, traction, and if the limb is pale, there's absent pulse, cold, there could be vascular injury, okay? You have to inform the vascular surgeon. Then sensory loss means there's neurological damage, okay? Then in the secondary survey is the imaging. Now the patient has settled. Now you go for investigations. Do not rush the patients for the investigation. First, you have to assess, you have to save the life. The patient has to settle down, okay? All the shock has to be over, or at least come to the minimal optimal level is blood pressure, okay? A pulse. Then you take the patient for the investigations. Okay, in the radiograph, there's trauma series, okay? So all patient needs trauma series. So trauma series consists of the cervical spine X-ray, chest AP view, not the PA view, the pelvis, then the part X-ray, okay? So C-spine, chest and pelvis are part of the trauma series. Then what is injured, you do that part X-ray, okay? And nowadays, there's a trend to do the whole body CT, okay? Not in our part, but in the Western world, they do the whole body CT. It is just completed in 1 to 2 minutes. It takes at once, and at once you get, you know what is fractured. Now, if you're trying to do the part X-ray, you have to change the position several times, okay? And you'll be hurting the patient. But one defect of this whole body CT is you get a lot of radiation, okay? And there's a condition known as SCIORA, which is the spinal cord injury without radiographic abnormalities, okay? So you have done CT scan, you do not see any bony injury, okay? But the patient is paralyzed, he cannot move the limbs, okay? So that condition is known as SCIORA. That means at least there is some contusion in the spinal cord, okay? And that can be seen in the MRI, but not in the CT. So MRI is not safe in unstable patients because MRI takes a long time, at least half an hour. To take an image of a part, it takes at least half an hour, MRI. But it's not that with CT. It just takes the picture, then the computer or the software makes the picture. But in MRI, all detailed picture has to be taken. So it takes a long time. So you cannot leave the patient in the MRI table, okay? The other is the USG fast scan. okay, focus assessment with sonography in trauma, okay, and this has replaced diagnostic peritoneal lavage, and it assesses the free fluid in the peritoneum, but it does not rule out visceral injuries. So if there is free fluid in the abdomen, then again you have to do a contrast enhanced CT, okay, to look for the visceral injuries. Now the resuscitation, okay, it follows ABCDE again. So inspect first the airway control, inspect for patency, foreign bodies there or not, secretion if there is suction needs to be done, do intubation as needed, tracheostomy as needed, and cervical spine care, gentle manipulation for the intubation, okay. So assess the breathing, okay, and if there is no chest movement, okay, and you cannot feel any air in the nose, just near the nostrils, then there is effective ventilation. So it could, the causes could be tension pneumothorax, hemothorax, and the flail chest. So if tension pneumothorax there and then, you put a wide bore needle in the second intercostal space. So the questions I think I'll take at the last, okay. Then the hemothorax, if there is, you put a chest tube, okay, in the fifth intercostal space. Do not hesitate, all should be done in the emergency itself, these procedures. And flail chest. So flail chest means there's a paradoxal movement of the chest. Suppose the rib, the same rib is fractured in two areas, then there will be paradoxal movement. So during breathing, actually the chest should inflate, but that segment will go down. So there's paradoxal movement and ineffective ventilation, okay. So indication for intubation is for the control of airway and prevention of aspiration in unconscious patients, and hyperventilation for increased intracranial pressure. So if there's increased intracranial pressure, one of the treatment is hyperventilation, okay. And if there's a massive facial trauma, there'll be swelling. So to prevent the obstruction beforehand, you can intubate, okay, to predict and intubate. So circulation, hemodynamic stability. So normal vital signs should be obtained, okay. Shock in trauma patient, it is always hemorrhagic until proven otherwise, okay. Then blood pressure is necessary to feel the pulse. So if there's no pressure, how will you feel the pulse, okay. So there are certain areas you feel the pulse, okay. If you can feel the carotid, femoral, and the radial, okay, you can at least guess that the systolic blood pressure is 80 mmHg, okay. But only the carotid you can feel, but not the femoral, then you think is around 60, okay. But nowadays we don't need this because the blood pressure monitoring is there and continuous it monitors. But in case it's not there, you can just put a hand and also guess. So the around this carotid, and if it's present, then you can at least be sure that the blood pressure is around 80 to 90, okay. So initial management of patient in shocks, okay. So direct control of obvious bleeding. So how do you control the bleeding? You put a direct pressure there, or you can put tourniquets, or even the blood pressure cuff you can put and stop the bleeding. Suppose in the forearm, you put in the arm the blood pressure tourniquet, blood pressure cuff, and you can stop bleeding, okay. And also you can put the clamps. You can take the artery clamps and just, if available, just clamp it, okay. And simultaneously put two large bore intravenous lines, okay, not the small one. Here in the picture it is blue, but actually it is the gray one, okay, which is the 16 gauze you have to put, okay, for the resuscitation for the IV fluids, okay. And if some patients, when they come there in collapse state, you cannot find the vein, okay. So you have to do a saphenous vein cut down. You have to cut down the saphenous vein and put the cannula in there. And in children, you can do intraosseous infusion, like in this picture. Just see in the tibia, there's a cannula put and infusion has been started, okay. So what to infuse, okay. Crystalloids are better than colloids, and crystalloids, normal saline and Ringer's lactate, you have to infuse, okay. At least 2 liters you have to give, okay. Colloids like this Hemacil I'll use later on, but initially you use the crystalloids, okay, because it distributes well within the intravascular space and also the intracellular space, okay. And also you have to monitor the urine output. So you have to put a catheter. So you have resuscitate the patient, but if there's no urine output, that means the resuscitation has not been proper. So you have to put a urinary Foley's catheter to monitor urine output. Okay, and you may put central venous pressure lines, and you have to do a ABG. Okay, in the ABG, what you look is for pH, base deficit, lactate levels, and PaO2 by FiO2, which is partial pressure of arterial oxygen with the fraction of inspiratory oxygen. Okay, so we usually in our practice look at the lactate levels. Okay, that is, but once the patient has gone to the ICU, we just do the ABG and look at the lactate levels. So if it is less than 2, the patient is okay. If it's more, then not resuscitate. Okay. So also the FFI2 is 500, 4 to 500, the patient is okay. But if it is dropping down to 300, then you can suspect that now there'll be some problem with the respiration. Okay. Then if it's 200, then the patient is slowly going into the ARDS, which is acute respiratory distress syndrome. Okay. So you give this isotonic crystalloids, the normal saline. Okay. But if you give a lot of fluids, okay, one problem is the dilution coagulopathy. Okay, so once you have given 2 to 3 pints of 2 to 3 liters of normal saline, then you have to give blood. Okay, otherwise there will be dilutional hypocoagulopathy. Okay. So, so 30 minutes have passed, so 10 minutes remaining. So we'll have to start the other session also. Okay, so be patient. And you have to give warm fluids. Okay, so if you give just the cold fluids, the patient will go into hypothermia. Okay, so again, there'll be other problems. So you give warm fluids. Okay, and other problem with giving a lot of fluid is if you're giving non-saline, there's chloride, so it could lead to hypochloremic acidosis. Okay, so and the lethal threat of polytrauma is this dilutional coagulopathy, acidosis, and hypothermia. So if these things are there, it's known as the lethal threat. Okay, the patient can deteriorate. Okay, very rapidly. So blood replacement is indicated by serial hematocrit monitoring, okay, and consider of angiography with or without embolization or operative intervention for hemorrhage control. So if there is massive bleeding in the pelvis, okay, large vessel bleeding. So if they are interventional radiologists, you can take the help of them, and then you can embolize, okay, embolize the bleeding point. So nowadays the new concept is this: you have to transfuse. You just do not give only fluids, okay? You have to give blood, fresh frozen plasma, and also platelets, like in the ratio of 1:1:1 to prevent this coagulopathy. Okay, this is known as balanced transfusion. Okay, so you give fluids, you give bloods, okay, and just not keep on giving fluid and blood. You have to also consider the fresh frozen plasma and the platelets. Okay, and that is, once you do that in the ratio of 1:1:1, it's known as balanced transfusion. Okay, but some people also practice is give 3 pints of whole blood, 2 pints of fresh frozen plasma, and 1 pint of platelets. Okay, so some people practice this way, but from where I've taken this one, it is mentioned that you give into 1:1:1, which is quite difficult. Okay, because to get fresh frozen plasma and platelets is quite difficult. Okay, because you have to send to the blood bank and they have to make it. Okay, so it's quite difficult. So hypotension in trauma is due to hemorrhagic shock, and there are classes of shock like 1 to 4. Okay, and the idea is class 1 is if there's less than 15% of body loss, between 15 to 30% is 2, and 3 is 30 to 40%, 4 is more than 40%. The idea is just if there's less of blood loss, you can just give crystalloids. But if there's massive blood loss, you have to replace blood. So, okay, they say blood for blood. So lots of blood has been lost. You have to give blood. You do not compensate that blood with all the fluids. Okay, you have to give blood, because if you are just giving the fluids, like there's no RBC, no hemoglobin, no oxygen carrying capacity, so all the homeostatic mechanism will be altered. So you have to give blood. Okay, so in trauma is mostly hemorrhagic shock, but they can be cardiogenic shock due to cardiac tamponade, and also neurogenic shock in spinal trauma, where the autonomic, the sympathetic ganglion is injured, and there's autonomic irregulation. Okay, so it lead to hypotension and bradycardia. Okay, and if the patient survives and stays long, okay, the patient may later go on to septic shock. Okay, so after resuscitation, you have to know what is the resuscitation endpoint, that you have fully resuscitated the patient. Okay, so in that you'll have the normal hemodynamics and oxygen saturation, lactate levels which will be less than 2, and no coagulation disturbance, normal temperature, urine output should be at least 1 ml per hour, and no requirement for inotrope like the noradrenaline and the dopamine. Okay, just a minute. Okay, just a minute. 5 minutes. Okay, now care of the injuries to specific tissues. Okay, so vascular injury, okay, you have to do a repair. Compartment syndrome, you have to do a fasciotomy. If there's a nerve injury, the nerve injury is graded in 3. Okay, neuropraxia, exentomesis, neurotomesis. So neuropraxia is due to just compression, is physiological, you just observe. Exentomesis also just observe. But neurotomesis means is a clear cut. Okay, the nerve has been cut. Okay, you have to repair or graft it. Okay, and dislocations, if it's there, you have to reduce as possible, as fast as possible. Okay, now the open fractures, just debride. Okay, open fractures, now I'll come later, so detail I will not go here. Just remember that open fracture needs debridement, timely antibiotics, okay, stabilization, and wound coverage. So if it is a tetanus prone wound, you have to give tetanus toxoid, and in some cases you have to give immunoglobulin also. Okay, so if it is more than 6 hours and the depth is more than 1 centimeter and there's a lot of devascularized tissue, you have to give tetanus toxoid. Okay, and if there are contaminants, dirt, soil, saliva, feces also you have to give. Okay, so if the patient has been immunized earlier in his life, the 3 doses which all we take, and also he has got booster dose. Okay, and if the wound is clean, you may not need to give the tetanus toxoid. Okay, but you do not know the history of the tetanus toxoid injection, and the wound is very dirty. So in that, to be safe, you just give the tetanus toxoid. And also, if he has no history of immunization, the patient says that he has never taken tetanus toxoid, then you also have to give him tetanus immunoglobulins. Okay. So now, if the resuscitation fails, which we have been all talking so far, okay, is just to prevent this systemic inflammatory response syndrome. Okay, if resuscitation fails, then there'll be widespread cellular damage. There'll be pan-endothelial dysfunction, microvascular permeability, and formation of protein-rich edema fluid and hypometasm, all will lead to systemic inflammatory response syndrome, which is in short is known as SIRS. And this ultimately will lead to multiple organ failure. Okay. So when do we say that the patient has SIRS? Okay. So out of the 4 things, at least 2 things has to be there. Okay. So heart rate is greater than 90, WBC count is less than 4,000 or more than 10,000, respiratory rate is more than 20 per minute, and the temperature is less than 36 or more than 38 degrees Celsius. So if the patient has altered 2 of this, you can say the patient has systemic inflammatory response syndrome, and there also still you have to manage well. Otherwise, the patient will go into multiple organ failure. Okay, so or multiple organ dysfunction, and that will be seen like altered consciousness with cardiac failure, renal failure, and this coagulopathy, okay, and also this liver failure. So the patient will go into multiple organ failure, and you cannot save the patient, okay. Once the patient goes into multiple organ failure, you cannot save the patient. So now we'll go into damage control orthopedics, okay. So it's a widely accepted principle and prevents the second hit phenomena. Okay, what is second hit phenomena? I'll just tell you. And damage control orthopedics, what does it? Stages the definite care to avoid adding the overall trauma that the patient has undergone. Okay, so when a patient gets trauma, okay, that is the first hit. Okay, so already that's the first hit, and although all in his body, like the cytokines, the leukotrienes, is all coming to play. Okay, all the cascades are going, and the inflammation is starting in the body. Okay, so there's a surge of this inflammatory mediators, cytokines, which peaks in 2 to 5 days after trauma. Okay, so we do not want to operate the patient in this phase. Okay, so we have to avoid this. Okay, so once the patient settles down, then only we go for definite surgery. We do not hurry to fix the bone. Okay, so the patient has to come over all this, then only we will fix the bone. Okay, so leukocytes are primed and easily activated. So the patient has trauma, he has the first hit, all his leukotrienes, cytokines are very much activated in the body, is in surge, and you operate at that. Okay, students, we are still in this damage control orthopedics. Okay, so I've just told you a little bit, known as DCO. Okay, so now you know what is first hit, what is the second hit. Okay, so damage control orthopedics tries to prevent the second hit phenomena. Okay, okay, so why is that important? As I just told you, it may lead to this acute respiratory distress syndrome or multiple organ failure. Okay, and traumatologists will only treat life-threatening injuries during this inflammatory window. That means we just try to just minimally stabilize the bone with external fixator. Okay, not do definite treatment and come out of the operating room. Okay, so definite surgery is done only after restoration of the endpoint resuscitation parameters, which I just told you. So I'll just show you one more time this endpoint resuscitation. Okay, normal hemodynamics, oxygenation, lactate levels less than 2, which is shown by the ABG. No coagulation disturbance, that is the prothrombin time is less than 1.4. The body temperature is normal, and he has good urine output. Okay, and does not require any inotropic support. Okay, so after that we do the definite treatment. So I have already told you, but just let me read to you this one. Release of mediators and induction of SIRS is dependent primarily on the severity of the trauma sustained, the first hit phenomena. Okay, any subsequent activation of various molecular cascade during surgical process is termed the second hit. So we want to avoid the second hit. Okay, now the limb salvage versus amputation. Okay, whether if the limb is crushed, whether just to amputate it or try to save it. Okay, so in case of polytrauma patients, okay, so where the life is at stake, okay, you can amputate it to save his life. Okay, but in case it's just a mangled extremity, only the musculoskeletal system is involved. Okay, maybe his tibia is fractured, is an open fracture, grade C, with all other body systems. Okay, then you can take time, try to save the limb. But if it's a polytrauma, we will try to save the life. So do not take long time reconstructive surgery and put the patient at stake. Okay. So in case of polytrauma, limb salvage is rarely indicated, as complex reconstructive procedures are time consuming and result in second hit with significant immune physiological compromise. Okay, immune and physiological compromise. So summary, okay, for this polytrauma, follow ATS principle always. Okay, and resuscitation should be prompt and adequate to prevent systemic inflammatory response syndrome and multiple organ dysfunction syndrome. Okay, and damage control orthopedic principles should be applied to prevent the second hit phenomena. Now with this, we finish this polytrauma and we will go into open fracture. So what is open? So sorry, just a minute. Okay, what is open fracture? The definition: it is a break in the skin and the soft tissue leading directly into or communicating with the fracture and its hematoma. So there's a direct connection with the fracture and the external environment. Okay, that is known as open fracture. Okay. So if you look at the epidemiology, 3% of all limb fractures are open. Okay, and if you look at this table, you find that this in the upper and the lower limb fractures, the percentage is more for the open fractures, and for the lower limb, the open fracture percentage is more. But if you look at the spine, this is 0, means spine injury is rarely a open fracture. Okay, most open fracture is lower limb injury. After that is the upper limb injury. Okay, so mechanism of injury is mechanism of injury is a high energy trauma. Okay, it could be road traffic collision or fall from the height. Okay, open fracture classification. This is important for you to understand and from the exam point of view. Okay, so there are two classification systems for open fracture. One is the Gostillo and Anderson, and one is the AO open fracture classification. But the AO open fracture classification is very complex and impractical for the clinical practice. So no one is using it. Okay, the used one is the Gostillo and Anderson. Okay, this was given. Gostillo and Anderson gave this classification is 1976, and it holds till today. Okay, but it was revised in 1984 to include some parameters which are missing, which was done in 1976. Okay, in 1984, the 3 was broken down into 3 ABC. Okay, so Gostillo classification is simple and remains a useful tool, but there are some demerits of it. Okay, it is based on wound size, level of contamination, and osseous injury. And the critique is that it says very less on the soft tissue injury. Okay, but it says it just analyzes this soft tissue, but not in detail. Okay, so it gives some idea, but it's not in detail. So there are some limitations. Okay, limitations are inter-observer agreement is only 50 to 60%. Means like open fracture for somebody maybe to me it seems as Gostillo type 2, but to some it may seem as 3. Okay, because so that is the defect of this. Okay, and only 50 to 60% there's a validity. Okay, and does not account for tissue viability and necrosis. Okay, it takes into account of this soft tissue, but does not take into the account of this viability and necrosis. Okay, so later you'll see in the classification there is comment on this soft tissue, but not on this viability and necrosis. Okay, and grading may change after the debridement. Okay, suppose in the emergency it is graded as 3A, but after the debridement it may change into 3B. So grading is done mostly in the operating room. Okay, you have one diagnosis in the emergency room, that grading may change in after the first debridement. Okay, and it does not comment on the nerve injury, and also does not comment on the gunshot injury. Okay, so these are the limitations of the classification. So type 1, the wound size is less than 1 centimeter. It's a clean puncture wound. Okay, soft tissue is minimal damage. The fracture is not comminuted, is a simple fracture, short oblique. Okay, then is a low energy. This is type 1. So if you look at this picture, you can just see a puncture wound. Now look at this. Okay, this is type 1. Okay, type 1, just a small puncture wound. Okay, rather than the outside force coming and hitting that part of the body and injuring the skin, then the soft tissue, then the bone, what has happened here is the deforming forces. After the deforming forces, the bone has fractured, and in fact, the bone has come from inside to out. This is known as the inside out wound. Okay, the bone has pierced and made a small puncture. Okay, so this is the type 1. Okay, so type 2, the wound size is more than 1 centimeter, but less than 10 centimeter. There's soft tissue, little soft tissue damage, moderate crushing. The fracture, there's moderate comminution, and some low energy. That's a type 2. Okay. Type 3, the wound. Type 3 is divided into A, B, and C. Okay. So type 3, the wound is more than 10 centimeter, and there's contamination. Okay. Contamination of the soft tissue. Fractured bone can be adequately covered by the soft tissue. There's contamination, there's soft tissue damage, but the skin covers the wound. Okay. In this type 3A, fracture is comminuted and is a high energy. Now this is type 3A. Okay, so this is the thigh, this is the knee, this is the femur, which has come out. But now look at this. Okay, it's more than 10 centimeter. The soft tissue damage is there, but if you push this femur back into his thigh, you can close the skin. Okay, so that's why it is type 3A. Now type 3B. Now if you look at the wound of the type 3B, okay, you cannot, this one is like an abrasion, and you cannot cover the soft tissue. The skin is gone. Okay, so this falls in type 3B. Now, the criticism of gustula andis system is like this: like the wound is large, but the soft tissue damage can be less than the skin wound size. Okay, but in sharp injury, the wound size is very small, but there's lots of damage beneath it in the soft tissue. Okay, so that is also one of the criticism of this gustula andis, which emphasizes more on the wound size. Okay, and soft tissue damage, there's periosteal stripping, and this is only found during the operation. Okay, this periosteal stripping. So if there's periosteal stripping, but still the wound size is just 1 centimeter or maybe 4-5 centimeter, it does not go into type 2. It goes away straight into type 3B. That everybody has to understand. Okay, so periosteal stripping straight away to 3B. Okay, fracture severely comminuted, and energy of trauma is high energy. Okay, so there's a skin loss. Okay, after debridement, look, there's a skin loss, so it cannot be covered by his own skin. Okay, so it falls in type 3B. So type 3C, okay, is the wound side is large, no adequate coverage, but the main thing of type 3C is there is a vascular injury which has to be repaired. Not only vascular injury, but the injury is such grave that you have to repair the arterial injury, otherwise his limb will be damaged. Okay, or it will be damaged. So the fracture is severely comminuted, the energy high energy. Okay, so if there's a vascular injury, you have to do a CT angio to find out, okay, the arterial damage. So here you can see the dye flowing, but here where there's a fracture, you cannot see. There's a thin dye going down, but this branch has been lost, and there's leakage of dye. So there's arterial injury. Okay. So not included in the classification: gunshot wound, segmental fracture, traumatic amputation, or near amputation. So all these go directly into type 3. Okay, gunshot, segmental fracture, and traumatic amputation or near amputation. And so why use this classification? Okay, so it gives some idea about the fracture healing and also infection. So if you see grade 1, the infection rates are very low, 0 to 2%. Okay, and 3C, it goes so high. Fracture healing also in type 1 is 28 weeks, around 7 months, whereas in type 3, it's around 9 to 10 months, or even maybe more. Okay. So what are the organisms, okay, involved? So when the wound is left open, they are more prone to this hospital-acquired infection, nosocomial complaints like the Pseudomonas and other gram-negative. Okay. And currently, most open fracture infections are caused by Staphylococcus and gram-negative rods. So some of the bugs are, so in blunt trauma is mostly staph, strep, blunt trauma, low energy, gunshot, okay. Farmland is Clostridia, okay. So if it's a farmland, you have to consider this and give antibiotics accordingly. Freshwater Pseudomonas, seawater Pheromonas, and war wounds, high energy gunshot, gram negative, okay. So these are the organisms. So what antibiotics to give, okay. So in type 1, you just give a cephalosporin. Is a first generation or second generation. You can use cefazolin or cefuroxime, okay. In type 2, also you just give cefazolin or cefuroxime, first or second generation cefazolin. But in type 3, you have to add a aminoglycoside to that, okay. And if it is farmland injuries, okay, you have to add this penicillin. Penicillin 2 million units every 4 hours, or 10 to 12 million units 24 hours, okay. And if unavailable, you can use this metronidazole, okay. So this also is important, what antibiotics to use, okay. Type 1 and 2, just first or second generation. Type 3, you have to add an aminoglycoside. If it's farmland injuries or contaminant, you have to use penicillin or metronidazole. So the goals of treatment is preserve life, preserve limb, preserve function. At the same time, prevent infection, fracture stabilization, and soft tissue coverage. Now, the stages of care for the open fracture, okay? How will you stage your treatment plan? So initial assessment is when the patient comes into the ER, then just follow the ABCS, ATLS protocol in polytrauma cases. Then there's emergency room management, and also then the primary operation, secondary operation, and the rehabilitation. So it is, the care is categorized into initial assessment, primary operation, secondary operation, and rehab, okay? So initial assessment is still the emergency room. Then primary operation means you take the patient to the emergency operation room and do the first debridement and also stabilize the fracture temporarily. And second operation, then you do the skin and soft tissue reconstruction and bone reconstruction if required, okay? Then the rehab. So initial assessment and management. So just document the neurovascular status and just do local irrigation, just 1 to 2 liters, and compressive dressings. And you apply the splint. When you apply the splint, if possible, try to realign the fracture. Just do not leave it in the deformed state. Try to give a little bit traction and realign the fracture. And do not send culture from the emergency department, okay? Because from the emergency department, what you do is all just, so you're taking the swab from the superficial skin, okay? It will not grow proper bugs. It has to be taken from the deep, okay? That can be done in the operating room. Actually, is not required also, okay? And check the pulse of the limb, motor power, and the sensation, okay? And documentation is very important, okay? The initial documentation is very important, okay? For the management of the patient and for the counseling of the patient and the patient part. So Gustilo recommended administration of 2 grams of cefamandole on admission and 1 gram every 8 hours for 3 days only in type 1 and type 2 fracture. But in our practice, 3 days is not enough. We go for quite a long time, okay? And type 3 open fracture, he recommended an aminoglycoside in the dose of 3 to 5 mg per daily that I just told you before. Okay, nowadays, previously, classification was very important because if you are conveying the message to your seniors, you have to give a proper classification so that you can visualize. But nowadays, everybody has the phone, okay, the smartphone, so you can take pictures and you can, that's also one form of document. And if you have to show your seniors, it's more easy, okay, because seeing the picture, like you can plan more better way than listening over the phone and them classifying and you visualizing. So this is better, okay? So nowadays, we all just use our mobile phones and take photos, okay, for cross consultation, for opinion with our colleagues. So that can be done, okay? And besides that, before dressing, you take the picture. Then if somebody wants to come to see, you don't have to open the dressing again. You can just show him in the on this mobile, okay? So primary surgery, now after the emergency management, you take the patient to the operation room and objective remains the same, but we take it for the wound debridement, okay, and definite injury assessment and fracture stabilization, okay. If it's type 1, you can there and there give the treatment and put a plate and nail, but in type 2 and 3, we do not do that. We just put a temporary external fixator, okay. So in the emergency room, you have to wash it very well with soap and saline, okay, and you have to define the zone of injury, do an extensive debridement, excise the margins, okay, and when debridement, always you start from the periphery, then go inside, not from inside to out, okay. And after debridement, you have to assess these 4 C's, okay, color, whether the muscle is red or not, whether it is the consistency, whether it's friable or not, okay. If it's friable, you have to keep on. Friable means you hold the muscle with your artery forceps and you try to pull, it just comes off easy. That means it's friable, it's not healthy. So that you have to take it off. And capacitive blood, when you cut the muscle, it should bleed and the muscles should be contractile. If it not, then again you have to keep on debriding, okay. Bone ends are also exposed and debride, irrigate, and serial debridements should be done, okay. Serial debridements should be done. Maybe you can again take the patient in 24 to 48 hours and even 72 hours. Repeatedly, you have to take the patient to debridement. And debridement is more better than adding a lot of antibiotics, okay. Nowadays, the antibiotics which I showed you, more than that, the other better antibiotics are available. More than that, just adding the antibiotics will not do the job. You have to take the patient to the operation room time and again to debridement, okay. So the irrigation in the operation room, you irrigate well, not like in the emergency with just 1 to 2 liters. Like if it is type 1 fracture, 3 liters, type 2 is 6, and type 3 is 9 liters. This was recommended by the England, okay, and you can use the normal saline to the washing, okay. So when to cover the wound? You cover it as soon as possible, as early as the wound allows. So if you cover the wound early, less than 72 hours, okay, the infection rate is low. More than 72 hours, the infection rate is quite high, okay. So, but you should not be in a hurry to cover it. The soft tissue should allow you to cover it, okay. That means it should be healthy granular tissue should be there, okay. So the dressings, okay, how you dress, okay. Dressings, you can just put a rubber band. Wet to dry dressing means you have to soak the gauze in normal saline and just squeeze it and take out all the saline. Just the dressing should be just moist, okay. That is wet to dry dressing. Semi-permeable membranes, antibiotic beads can be made, okay, with this bone cement, and antibiotics such as vancomycin, tobramycin can be kept, and we can make these beads and keep it in the wound, okay, pack it in the wound. And one of the very good dressing is the vac, okay, that is known as the vacuum assisted closure, okay. So this vacuum assisted closure is very useful if there's a lot of swelling, okay. What you do is you do the debridement, okay, then you put a sponge, okay, there, and you just cover it and then connect it to the put a suction tube and connect it to this machines. This gives a negative pressure, so it soaks out all the fluid, okay, reduces edema, it improves circulation, and it helps in generation of the granulation tissue. This is a very good dressing, okay, vacuum dressing. So the types of fracture stabilization, okay, how you stabilize, okay, you can just splint it, okay, good option if operative friction not required. So if fibula is fractured, it's an open fracture, but it's a fibula fracture, so you don't have to put a plate, okay, especially in the mid shaft, you can just put a splint. And internal fixation if the wounds are clean and soft tissue coverage is available. So if the wound is clean, if the soft tissue coverage is available, then you can do internal fixation. But you are not sure that like the wound is dirty, you still need debridement, then you do not put a plate or a nail, okay, you just put an external fixator and keep on dressing or take the patient to the operating room to do debridement. And once all is clear, then you can do the definite fixation. Never be in a hurry to fix the bone, okay. So fracture stabilization, vascular type 1, you can be treated as a closed fracture and you can do the debridement and just put a plate or nail, okay, in type 1 at one shot, but not in 2 and 3, okay. You have to debride, you have to put an external fixator, soft tissue has to heal, okay, then you do the definite fixation. So when you put an external fixator, it restores the length, alignment, rotation, and provide stability. Okay, and once you do that, then the soft tissue healing is good. So if the bones are still moving, then there's, suppose you have not put an X-fix, you just put a plaster splint. Okay, the bones are moving inside, means your infection will not be controlled. Okay, and the swelling also will not go down. So for this type 2 and type 3, it's very good to put an external fixator. So external fixator, the pros and the cons. Okay, the advantages are easy, reliable, stable fixation, no further damage is done, and avoids hardware in the open wound. Okay, the disadvantage is the pin track infection, malunion, and delayed union. But this is also not a problem, because nowadays we don't use external fixator for the definitive treatment. Okay, and there's a poor patient compliance, means there's an external fixator with rods and clamps all coming out from his limb. So there's poor patient compliance. The patient finds it very cumbersome and does not like this external fixator. Okay, so the key word is in this open fracture is scan, span, and plan. So scan means first you do the X-ray. Now suppose you look at this. This is a tibia fracture. Okay, this is an open tibia fracture. We have just scanned and done a radiograph. Span means you just put an external fixator, okay, and let the soft tissue heal. Okay, in the meantime you can plan, okay, whether you want to put a nail or whether you want to put a plate. You can plan that. So nowadays we use the term for the open fracture: scan, span, and plan. Okay, and this came from the AO group of people. Okay. So now for the wound coverage, okay, if it's a type 1 fracture, you can do a primary closure. But if it is type 2 and type 3A, you do a secondary closure. Secondary closure means you have to wait at least 1 week to close the wound. Okay, and if it's a type 3B where there's extensive soft tissue loss, you have to put a graft or flap. Okay, so flap could be just this muscular flap, fasciocutaneous flap, or the vascular graft. Okay, so if you look at this picture, look at this crush injury, all has been debribed. Now the wound is very clean, and then a flap, free flap has been placed. Okay, so the flap coverage for type 3B. Now salvage, whether to save the limb or the amputate. Okay, so vascular surgery can revascularize by bypass graft. Okay, but first, now if you look at this limb, this is the thigh and this is the leg. Look at this soft tissue damage. Okay, so if you want to save this, okay, first of all, the fracture, the bone has to stabilize. You have to put an external fixator at least stabilize the fracture for the vascular surgeon to do the bypass graft. Okay, then later on the plastic surgeons will cover this. Okay, but the salvage procedures are very long. Okay, time and again the patient has to go repeatedly to OPD, and it's a trauma, psychological trauma for the patient. Okay, so sometimes it is better to amputate than to save. Okay, amputate the limb, and later the patient will put a prosthesis. Okay, nowadays very good prostheses are available, and even now we have Paralympics. Okay, with patients running with bilateral prosthesis. So since good prostheses are available, okay, if you cannot salvage the limb, you do not try. Okay, because you try to salvage the limb, and while trying to salvage the limb, the patient may land up in this systemic infective response syndrome and multiple organ failure, and the patient may die. And that has happened in one of our patients. Bilateral limb was crushed, and we tried to save it. The patient stayed for 3 months in the hospital, and ultimately she died of all this dyselectrolytemia. Okay, so the decision would have been better if we had amputated the leg right early. The hospital stay also should be less, and she could have easily put bilateral prosthesis. Okay, so how to decide salvage or amputate? Important factors is, if the patient is in shock, you don't try to do long hours of surgery and try to save the limb. Okay, and warm ischemia means if the limb, if they have presented more than 6 hours. Okay, if you again try to if you try to vascularize the tissue by doing bypass graft or the repair, what happens is reperfusion injury occurs. Okay, and that may be also lethal to the patient. So if it is more than 6 hours, you may do a very good anastomosis, but the patient may die. Okay, so that also you do not try. And if the patient is more than 30 years also, you can just try to amputate if you cannot save it. Okay, so complications of infection is delayed union and non-union and osteomyelitis. So if it's an open fracture, definitely the union will be delayed. Okay, and also may go into non-union. And after treatment, you have put a nail or a plate, and it can go into it can go into osteomyelitis. Okay, so these are the complications, and you have to predict non-union. If there's severe bone loss, okay, and you have put a bone graft, still there's chance of going into non-union. That also you have to predict. Okay, so with this, we finished the class on polytrauma and open fracture. So I had a lot of slides and I rushed. I hope you understood what I just told you. These are just the guidelines. You go through your book and try to understand and capsulate what I just told you. Okay, in exam, this gustilo in open fracture is a very pet question. Okay, the classification of open fracture, you have to know that. Okay. So I think with this we end the class. So some people are raising the hand, but if you have any questions, you can type so that I can answer. We just have around